Welcome. My name is Raj Persaud. I'm a consultant psychiatrist based in London. And today I'm in conversation with Richard Brown, who's a senior clinical lecturer in psychology at the University of Manchester. And Richard is a world authority in a very interesting subject, which is medically unexplained symptoms. These are symptoms that patients have, often of a very physical nature. They feel very physical to the patient, but they're rather mysterious because doctors can't find any physical cause, often when they do objective testing. And this is a very big problem in terms of conflicts that often arise between patients and doctors, and is actually one of the central mysteries at the heart of medicine, which is how come so many patients can have so many symptoms which don't seem to be revealed by any physical investigation. But Richard, let me start by asking you how it was you got interested in this area. It sounds like it began when you were doing some research at the National Hospital for Neurological Diseases.
Yeah, it was the role I took when I completed my PhD in '99. I went to work with Michael Trimble at the National Hospital, and they see a variety of patients there, but a substantial proportion of them are coming in for tests on their symptoms to try and determine the cause. And in a substantial proportion of cases, no cause could be found. The variety of different symptoms you see, and extremely disabling, complex problems they are too.
And some of these patients you refer to in some of your recent papers had as many as 30 different unexplained symptoms.
Well, a history of 30, yeah, not 30 all at once, but certainly 10 symptoms perhaps at the same time, with a history of up to 30, yeah.
And could you say something about the kinds of symptoms that patients have?
I mean, it's very varied, but the kinds of symptoms you see there are obviously neurological symptoms because of the setting, but there'll be things like seizures or paralyses, problems with walking, problems with seeing or hearing. The whole range of neurological symptoms have a kind of medically unexplained counterpart.
And you quote some figures in your recent paper entitled Explaining the Unexplained, recently published in the Psychologist, that these are surprisingly common. You say that apparently, you quote research suggesting that approximately 8% of general practice patients have three or more currently debilitating symptoms and a long history of medically unexplained symptoms. And you also quote data that suggests the NHS spends £3 billion a year on medically unexplained symptom-related healthcare costs.
Yeah, I mean that's medically unexplained symptoms is a kind of complete category. I mean the functional neurological symptoms that I was talking about are only one small subset of that. But I mean every branch of medicine has its medically unexplained symptoms and syndromes, and collectively they cost billions of pounds. I think that figure you're quoting was from 2010, and the estimate then was that more money is spent on this category of complaints than on dementia, which I think rather illustrates the problem. In terms of prevalence, yeah, something like 80% of the symptoms that we will experience on a day-to-day basis have no explanation. And then if you go into, say, in primary care, yeah, as the figure suggests, 8% of people will have three current symptoms plus a long history. So it's,
And that very fact that so many symptoms can be unexplained, actually, we'll come back to this later, can be an important part of treatment, can't it? In explaining to patients that this is not that unusual, because patients can often be quite frightened by having symptoms that doctors can find no physical cause for.
yeah, I think that's right. I mean, certainly being able to say, look, this is something that happens all the time, is comforting to patients. I think people easily regard themselves as strange or unusual for having the problem, but citing the frequency can help allay that, I think.
Now, this is a group of patients that are often found very frustrating by doctors, and I'm particularly interested that you were drawn to do research on them, and you were drawn to find out more about this because it's not a popular research area. What are your thoughts about that? Why were you drawn to this?
I mean, I think it's my interests originally were in things like consciousness and executive function, psychology of that, and I did my PhD on hypnosis at University College London. And so, I mean, it's a fascinating area where we can use suggestion to create pretty compelling distortions in consciousness and in behaviour. I had no awareness of what medically unexplained symptoms were at the time, but when I went to the National and encountered these patients, it struck me that exactly the same things were happening with them as with their kind of hypnotic phenomena. So it's really my interest in consciousness that led me to look at these people.
Could you say a bit more about the work on hypnosis and how hypnosis can induce symptoms in patients?
Well, if you think, you can, in a highly hypnotizable individual, you can give them a suggestion that, for example, they're not able to walk or bend their arm or something like that. Then, if they're sufficiently suggestible, and even without hypnosis, interestingly, that suggestion will create a compelling alteration in their experience. And in that sense, the experience is no different to what someone with a functional neurological symptom or a medically unexplained neurological symptom experiences, although obviously in that case it's a chronic problem.
So this naturally leads us on, as you explain in your paper, to the concept of disassociation. Hypnotic phenomena and disassociation are linked, and there seems to be a link between disassociation and perhaps one model of understanding medically unexplained symptoms. Could you say something about disassociation and its history?
Well, historically, the dissociation model was developed by Pierre Janet in the 19th century, and in those days they used the term hysteria to refer to the phenomenon whereby people would experience these unexplained neurological symptoms. And at that point, it was thought that hypnosis and hysteria involve similar psychological mechanisms. And the basic idea is that a hysterical individual carries some kind of mental weakness or attentional deficit that leaves them susceptible to a kind of mental fragmentation in response to trauma or extreme emotion. So the idea is that their mind breaks down into separate components, and one of those components, perhaps containing a set of memories about a traumatic incident, can be activated by some kind of stimulus in the world or in the mind, and in being activated it creates a symptom. So the idea is that a similar process is occurring in hypnosis as well.
Now, in your paper, you refer to an important distinction between different ways of understanding dissociation. You could refer to it as a kind of detachment or as a kind of compartmentalization. Could you say something about what the difference is between these two different models?
Yeah, I mean, that's a very important point, I think. If you ask most people what they regard dissociation to be, they'll refer to an altered state of consciousness where people feel detached from the self or from the world. And the term depersonalization, derealization is often used to refer to that. And in the early dissociation work, that kind of experience wasn't considered part of the kind of the hysterical domain. What Janet was talking about and what subsequent dissociation theorists were talking about was symptoms like medically unexplained neurological symptoms, where there seems to be some kind of separation between separate compartments in the mind. And we believe that the evidence and all the work on mechanisms suggests that those two phenomena are qualitatively different. Hence, we make the distinction.
And just say a bit more about compartmentalization and what you're referring to when you speak about that.
Well, I think a really nice example of compartmentalization is a paper by Jarl Kuyk and colleagues in the Netherlands, who took a group of patients who had profound amnesia following a non-epileptic seizure or a medically unexplained seizure, and a group of patients who had amnesia following epileptic seizures. And they gave both groups of patients, they hypnotized both groups of patients and gave them suggestions for recall of material occurring during the seizures. And found that in the case of the epilepsy patients, absolutely none of them could recall anything about what was happening during the attack, suggesting that they hadn't encoded any memories at the time. Whereas 17 of 20 patients with non-epileptic seizures could recover information about what was happening when they had the event, which was then corroborated by external witnesses or recordings. So it seems that that information was in their mind somewhere, but they were unable to access it because of a retrieval deficit. So in other words, it's kind of compartmentalized in their mind, and the hypnotic induction and the suggestion enables them to access that compartment.
And you seem to me to be very attracted or more attracted to that compartmentalization model of understanding dissociation.
As far as I'm concerned, dissociation is really referring to compartmentalization. It's not really depersonalization or detachment, as I was talking about before. So in order to understand dissociation, you have to think about it as a compartmentalization to me.
And you mentioned Pierre Janet and the history of these ideas, and this takes us back to the beginning of psychoanalysis and links to another idea, which is that childhood trauma and repressed memories about childhood trauma could be underlying medically unexplained symptoms. And this was a very popular and remains a popular idea, but you seem rather skeptical about that idea.
Well, I mean, I'm not completely skeptical about it. I think that there are some patients whose symptoms can be traced to early trauma or trauma later in life. But I think, unlike others, I believe that it's not a necessary condition in order to experience these phenomena. And the data suggests that only a proportion of people have these kind of problems. And my view is that you don't need to cite trauma in order to explain them. So we need a model which can accommodate the role of trauma, but without relying on it.
Well, let's come back to your model that you advocate in a moment. But what about psychoanalysis and psychodynamic treatment approaches? Is there any evidence that these are particularly helpful with people with medically unexplained symptoms?
There is evidence, yeah. There was a recent review paper published on brief dynamic psychotherapies for medically unexplained symptoms, and the evidence is that they do work well. And I practice psychodynamic interpersonal therapy, Hobson's conversational model, with this particular group of patients, and I find it fantastically useful. But that model is no longer reliant on the idea that people have experienced trauma, whilst that might have been the idea that was originally proposed by Freud and Breuer. It's no longer considered a necessary part of that theory.
Could you say a bit more about that model and what that kind of treatment involves?
Well, in brief, psychodynamic interpersonal therapy, the goal is to develop a kind of emotional language with the patient using their terms, and to develop a kind of emotional connection that helps you understand how they manage their feelings, how they manage their relationships, and seeks to identify problems with how they manage their feelings and their relationships, and a link between those things and their symptoms. So, for example, someone may, when they're growing up, learn that they can't express particular feelings in their family, and perhaps learn to present symptoms as a way of obtaining care from others. And over time, that then becomes a kind of a way of life for them. There are many different ways in which you can work within sort of psychodynamic model, so it doesn't always have to be like that, but that's one example.
Now, the model that you've written about is called the Integrative Cognitive Model. Could you tell us a bit about that?
Yeah, the integrative model is a bit of a departure from previous theories because it doesn't rely on this concept of trauma, and it also doesn't rely on the idea that people are psychiatrically unwell. Previously, I think people have always assumed that there's some kind of anxiety or depression or other psychiatric problem that the person's denying, and that the symptoms are a way of kind of expressing their distress without having to acknowledge it consciously. And the model is basically saying that that's not required to explain these symptoms. And the key principle really is that you can think at least of some of these symptoms, particularly these neurological symptoms, as a kind of distortion in consciousness or a distortion in behavioral control that comes about as a result of a kind of an overactivation of an idea in someone's head, and as a result produces a compelling distortion in their awareness.
Part of an important component of the model seems to be the notion that people are hypervigilant for symptoms. They're very focused on bodily symptoms. Could you say a bit more about that?
Yeah, well, certainly when we originally published the model, the idea was that people who are constantly on the lookout for health threat or symptoms, are basically increasing the activation of this idea in their head to the point where that idea becomes so active that it starts to intrude into awareness as a current percept rather than a previous memory of a symptom, for example. So that's where this hypervigilance or over-attention to symptoms might play a role. Interestingly, in more recent research we've been doing, we've started to think that actually the opposite might be going on, and that it's not about hypervigilance to the body per se, it's about hypervigilance to the idea of the body. And if anything, people with a tendency to experience these symptoms are kind of cut off from what's actually happening in their body, and they kind of become reliant on what they think is happening in order to interpret bodily events.
Let's go back to some of these fascinating experiments you've written about. I'm particularly intrigued by this thing called the somatic signal detection task, in which participants have to decide whether a weak vibration has been delivered to their fingertip. And there's some very interesting results there that seem to differentiate people who are prone to medically unexplained symptoms. Could you say a bit about that?
Yeah, as you say, basically the task involves participants being presented with a series of trials where they have to say, did they feel a vibration or not? And it's a very subtle vibration delivered to their fingertip that's present on about 50% of trials. And on some of those trials, it's accompanied by a brief flash of light. And what we found is that on about 20% of trials where no vibration is presented, people will say they did actually feel the vibration. And that's more common when it's accompanied by the light. And these kind of false alarm responses, or what we call illusory touch experiences, correlate with the tendency to experience medically unexplained symptoms, or indeed symptoms generally. And we believe this kind of illustrates that a tendency to experience these kind of distortions plays an important role in the development of the problem.
And you also refer to some fascinating experiments called, or linked to, something called the rubber hand paradigm. Yeah. Could you explain what the rubber hand paradigm is?
Yeah, that's a most odd phenomenon. For anyone who's experienced it, they'll know what I mean. Essentially, you place a rubber hand in an anatomically plausible position in front of the person, and you place their real hand out of view, and you simultaneously stroke the back of their hand and the back of the rubber hand with, say, a paintbrush in a kind of synchronous fashion. And for people who are susceptible to the illusion, quite quickly they'll start to feel like the stroking on the back of their hand is actually coming from the rubber hand, the so-called rubber hand illusion. And it's a most unusual experience of kind of body disownership. And you might think that, given what we've said about medically unexplained symptoms being a kind of distortion in consciousness, you might expect that to correlate with the tendency to experience the rubber hand illusion. But actually what we find is that it negatively correlates, such that the more likely you are to experience the rubber hand illusion, the less likely you are to experience symptoms. And we think that's because the rubber hand illusion is driven by visual input overriding tactile input or bodily input. And we think that these people are less driven by that kind of what you might call bottom-up information, and more driven by ideas in their own mind, the sort of top-down information, hence them being less susceptible to the illusion.
So what are the practical implications of all this psychological theory in terms of treatment?
Well, that's a good question, and I think for me one of the main implications is that when you're explaining to someone what's going on with the symptoms, you're not reliant on saying, well, there must be some kind of trauma in your past that you're just not able to think about. You're not reliant on saying, well, you must be depressed or anxious. You can say, well, these are a reflection of the way the mind works normally. The mind's consciousness and behavior, their interpretations, they're based on what you know and believe and expect to happen. And sometimes those things can go a bit awry. And you can refer to things like the placebo effect or hypnotic phenomena or other illusions to illustrate what might be going on in these symptoms. And that's a very kind of normalizing explanation that it tends to be quite palatable to patients, but certainly much more so than a psychodynamic explanation, which can be quite challenging for people, even if there are psychodynamic factors that are relevant.
What about the fact that I've seen with a lot of these patients who I've seen myself is that they are very, very keen on testing and repeat testing and MRI scans and yet another test because they refuse to accept that tests are producing no physical basis for their symptoms, and they can be very persistent in the pursuit of further tests. And the psychological theory is that this pursuit is not helpful to them. So how do you talk to them about continual testing that they seem to desire?
I mean, to begin with, I would say that it isn't my experience that that happens very often, and it may be that I see patients in the psychology service where people have already accepted in their own minds that there's a psychological explanation, otherwise they wouldn't come and see me. So typically the people I see are actually quite accepting of the idea that there's no medical explanation and aren't really seeking further tests. But certainly I have encountered patients who are like that, and in those cases repeatedly seeking tests and going to different doctors, seeking second and third opinions, almost certainly isn't helpful. And they're trying to understand what's driving that behaviour is probably the starting point for treatment.
Now, one of the things that I feel you haven't emphasised, and I'm sure you're going to correct me on this point, but which I feel is very relevant. I mean, you've been focusing on attention, focus, bodily symptoms. I'm very interested in, I think that these patients have a very interesting view of what health is, in a sense that they seem to think that being healthy means being devoid of any physical sensations or symptoms. And when I try to explain that actually there is no such state as perfect health, and that even very physically fit and healthy people have good going experiences or symptoms on an average day, they find that quite intriguing. So what are your thoughts about the idea that actually it's their top-down view of what health is that might be quite important as well?
Well, certainly the model we've been developing very much emphasises the top-down view, which in influencing their symptoms. And I do encounter patients who struggle with the idea that actually a healthy body does obviously produce symptoms. And I think, my specialism is these functional neurological symptoms or unexplained neurological symptoms, and there the typical response will be, well, how do you explain me having a seizure then, or a paralysis? Surely those aren't everyday symptoms for most people, and that's probably a fair comment, really.
And what do you say when that happens?
Well, that's where I would say, well, I don't think this is the same as someone experiencing a bodily sensation that is coming perhaps from having slept funny, or from having been dehydrated or whatever. I don't think there is a simple physiological explanation for those symptoms, which perhaps accounts for the other symptoms that you're referring to.
And if you had one tip or one piece of general advice for doctors or psychiatrists or psychologists who are treating people in this area, what would that piece of advice be for the clinicians?
Well, there's so many things, but I think probably one of the main things I'd emphasise is that these patients with these kinds of problems aren't typically attention-seeking. I think that's the belief that's held by certainly many physicians that I've encountered, and I think that's rarely the case. Similarly, the idea that they have to be depressed or anxious or traumatized, I think those are unhelpful messages to give.
And if you are someone who is suffering from medically unexplained symptoms, you've got symptoms, doctors haven't been able to explain them satisfactorily to you, particularly in terms of a physical cause, what would your tip or advice be to those people who might be listening to this?
Well, I think what you need is a clear-cut diagnosis, and I think sometimes what will happen is a doctor will be reluctant to actually give a clear-cut diagnosis. They'll say, well, we can't find anything wrong with you. Good news, there's nothing wrong with you, and the patient's left thinking, well, but hang on a minute, I've got all these symptoms. So first and foremost, what you need is someone to say, this is the problem. We think you've got a functional neurological symptom or a non-epileptic attack or whatever. And once you have that diagnosis, then you can seek treatment. There aren't, unfortunately, that many specialist services for these kinds of problems, but they do exist in the bigger cities. And there are some good patient information leaflets available, and there's some good websites as well, so they may be starting points for patients.
So you said that it's very important to actually have a diagnosis, but could you say a bit more about what those diagnoses might be if they're not if they're not medical diagnoses in the conventional sense? Could you give us some examples of those?
Well, a diagnosis, for example, of psychogenic non-epileptic seizures.
Hang on a second. What is a psychogenic non-epileptic seizure?
Well, a neurologist, for example, will will diagnose patients with blackouts or convulsions or whatever, and a substantial proportion of those won't have a medical cause, and those patients will be given the label functional seizures or non-epileptic seizures. We use the term psychogenic non-epileptic seizures because there are seizure-like attacks which appear to be epilepsy-like, but actually have a physiological cause. Hence the use of the word psychogenic. But that's the kind of the non-epileptic attack label is probably the one that's most commonly used by neurologists.
But really, to have the kind of confidence to hand down a diagnosis like that or give a diagnosis like that requires a huge amount of confidence in the clinician and requires them to be quite specialist, I would argue. I mean, I'm not saying you're wrong, but I'm saying that these patients have got to find someone who really has the confidence to give that kind of diagnosis.
I think that's true to an extent, but certainly any epileptologist, for example, will be very used to seeing these kind of patients and should be prepared to offer that kind of diagnosis. It becomes less clear with other symptoms who the best specialist to see is, but certainly in the case of seizures, which are a particular interest of mine, an epileptologist should be able to make that diagnosis.
But you seem very adept at avoiding conflict with the patient. This is an area where there's often a lot of conflict because the patient has a different view as to what's going on to the doctor. Could you say something about that?
Well, I think the starting point is that you need to understand that their symptoms are real, and just acknowledging that and acknowledging that it's confusing and that you can understand from their point of view that here are all these people telling them there's nothing wrong with them, and yet they feel very much that there is something wrong. That kind of simple human empathy, I think, is actually extremely powerful. That's really the basis of the psychodynamic interpersonal model that we use, is just trying to empathize with the person, and that we find is tremendously powerful in engaging people.
Richard Brown, thank you very much indeed. Richard Brown is winner of the British Psychological Society's Division of Clinical Psychology May Davidson Award and has written many papers on this subject. The paper we've been referring to is entitled Explaining the Unexplained, published in the Psychologist. And if you are interested in doing the Continuing Your Professional Development module that is linked to this interview, then the keyword you will need to unlock the module on the Royal College of Psychiatrists website, that keyword is unexplained. Richard, thank you very much indeed.
Thank you.